Dementia is one of the most challenging conditions that the medical profession and the aged care community face. Many people living with dementia will experience behavioural and psychological symptoms during the course of their illness and may even develop behaviours that place themselves and others at risk. This can be a challenging situation for both dementia patients as well as their carers. As a result, antipsychotic medications are frequently used to reduce the impact of such symptoms. However, there is growing concern from healthcare professionals and the broader community that antipsychotics are being overprescribed. In this video, we will hear from doctors and other healthcare professionals who are involved in managing antipsychotic medications in patients with dementia. The challenge for healthcare professionals is to identify situations where antipsychotics can be reduced or deprescribed and to look for alternative solutions for managing symptoms.
Antipsychotics are vastly overprescribed. We know that on the average about 30% of residents in nursing homes are on antipsychotics. We know antipsychotics are associated with serious side effects such as increased risk of stroke and death, also faster rate of cognitive decline, more falls, extrapyramidal or Parkinsonian side effects. So it behoves the clinician to try and avoid using antipsychotics unless absolutely necessary. Antipsychotics that are prescribed for people with dementia come in two broad classes: traditional or first-generation antipsychotics, such as haloperidol, commonly called Serenase, and second-generation or atypical antipsychotics. Risperidone or Risperdal is the major one prescribed in that class. Olanzapine or Zyprexa would be another one. These antipsychotics are generally prescribed to try and control behaviours such as agitation, aggression, screaming, wandering, and they're not always appropriately prescribed.
GPs play an important role in monitoring the use of these medications. So dementia patients are commonly prescribed when they are, say, first discharged from hospital, have been sort of treated for an acute problem, usually a delirium. The second scenario is when they are in an aged care setting where they are disruptive to fellow residents and staff. And finally, when they are out in the community, so when they are sort of disruptive to family members. Many of these patients have got fairly complicated comorbidities and fairly complicated medical histories also. A collaborative effort needs to be undertaken between the GPs, the family, as well as the aged care staff. I think GPs should first of all review the medication, make sure that it's appropriate. They should also think about non-pharmacological interventions. We need to exclude a delirium, because sometimes disruptive behaviors and agitation come out from a delirium, so you need to do screening tests for that. Concentrate on patient-centered activity like physical exercise and recreational activities. And if it's suitable, they should make sure that they are reviewed at least 12 weekly with the aim of deprescribing it if the time or situation permits it. We also have to take into account the regulations that are required to monitor the safety of the use of this medication.
GPs can also take part in an NPS Medicine-Wise clinical e-audit designed specifically for managing dementia patients who are taking antipsychotics. The e-audit can help GPs to identify patients who should be deprescribed the antipsychotic as a priority. Many dementia patients have other medical conditions that complicate the prescribing picture. Patients may exhibit difficult behaviours because they are in pain and cannot explain themselves clearly. Let's examine the fictionalised case of a dementia patient who has been prescribed antipsychotics. June is 83 years old and lives in an aged care home. She's been diagnosed with Alzheimer's disease. She also has a history of osteoarthritis and incontinence. Over the last 6 months, June has been prescribed increasing doses of risperidone to control these behaviours. Despite this, her behaviours continue and she is transferred to an aged care home with a secure dementia unit. When she is admitted, June is lethargic and unable to walk. She requires assistance with all daily activities. The unit's GP reviews June's medication after discussions with June and her family, as well as with aged care staff. Her GP decides to taper June's dose of risperidone. As her dose is reduced, June's level of alertness improves. The GP realises that June's reluctance to walk was because of pain from her osteoarthritis. After starting on paracetamol, June regains some of her ability to walk. Although she still exhibits some of her previous behaviours, staff manage them through a variety of interventions such as redirection and walking. June's case is a good example of how antipsychotics are often no longer required when patient needs are identified and met.
Best practice is having a patient who's exhibiting behaviours which are distressing to the patient or to staff or to other residents, or particularly if they're dangerous to themselves or to others, and where no cause has been found, psychosocial treatments have not worked, then medication may be indicated. I generally look at other medications first, such as citalopram as an antidepressant. There is some evidence that that may reduce agitation. Cholinesterase inhibitors may also be helpful. But there are times where the patient, particularly with aggression, or particularly if they're psychotic with aggression, that antipsychotics will be the first treatment we would use if we're using medication. I'd start at a low dose and very gradually increase. And I do prescribe antipsychotics, and I've gone through all the steps of trying to find the cause, not finding a cause, trying psychosocial measures, and that's not working. But the patient is aggressive or being particularly dangerous to themselves or to others, and then there's a balancing act, so that the benefits in that case may outweigh the possible side effects. So I get consent from the patient if possible, but if not that, from a proxy, like the family member, and then I'll start low and go slow. The best data is for risperidone. I start at 0.5 or even 0.25 milligrams. That's half the 0.5 milligram once a day, and gradually build up that dose. I never go beyond 2 milligrams a day. Other side effects of antipsychotics can make people drowsy. Some antipsychotics have anticholinergic side effects, which means people get more constipated, might have urinary outflow problems. Other antipsychotics, such as olanzapine, are associated with metabolic syndrome, so increased cholesterol, increased sugar, obesity. So there are side effects that need to be considered and weighed up the benefits versus the side effects before beginning an antipsychotic treatment. Antipsychotics should not be used in general, if possible, but if the indication's there are some specific cases where it would be undesirable to use an antipsychotic. So, for example, people with Lewy body dementia are much more sensitive to the Parkinsonian side effects of antipsychotics, particularly the first generation or traditional antipsychotic medication. People with a history of stroke or heart disease may be more at risk of having a vascular adverse event from the antipsychotic, such as a stroke. There are a number of behaviours where antipsychotics have not been shown to be a benefit. They're not a benefit for treating depression. They're not a benefit for treating inappropriate vocalization, calling out or screaming. They don't work well for sexual disinhibition. They don't work well for wandering. So the main indications for using them are aggression, psychosis, and agitation. If the decision is made to use medication to manage a behaviour, there are non-antipsychotic medications that should be considered. There's been a very elegant study using paracetamol, 1 gram 3 times a day, showing that reduced agitation, and it wasn't people who were chosen particularly because they had pain. So it's worth trying that as a first step. There have been some other studies using citalopram, an antidepressant, showing that that had effects on reducing agitation as well. There's some work with cholinesterase inhibitors, such as donepezil, rivastigmine or galantamine, showing that can reduce some abnormal behaviours. So these should be considered prior to prescribing an antipsychotic. If a patient is prescribed an antipsychotic, it is important that the patient have regular reviews, and this can be by the nursing staff, but certainly by the doctor as well. And there should be a trial reduction within 12 weeks of starting the antipsychotic to see if an antipsychotic is still required. If the behaviour has settled, the patient may not need the antipsychotic anymore. If the patient hasn't settled, there's been no effects with the antipsychotic, then clearly it needs review. Or if there are adverse effects occurring because of the antipsychotic, then review is necessary. It's important to taper the medication slowly. There's also a temptation to use substitute medication, such as benzodiazepines like Valium. that should be resisted if possible. When deprescribing, it's important to remember that management of the patient is a team effort. There are the nursing staff, there's the management, there's the family, and all of them need to be considered and consulted in doing this. Nursing staff may be quite apprehensive about withdrawing medication. They feel that the behaviours for which the medication was prescribed in the first place may re-emerge. So they need to have some strategies how to handle the behaviours if they do reoccur, but also some reassurance that in the vast majority of cases, behaviours don't re-emerge with gradual withdrawal.
Pharmacists have a supportive and collaborative role at several levels. As a retail pharmacist, patient coming in with a prescription for an antipsychotic medication hopefully will be told about what to look out for with the medicine, along with the carer, and hopefully we'd talk about potential side effects. As a consultant pharmacist working in aged care, pharmacists will educate staff about medications, what to look out for, what to expect when medication doses are changed or when a drug is started or stopped. And also pharmacists are involved in medicine reviews for patients. With patients with dementia, oftentimes there'll be behavioural problems with dementia, behavioural and psychological symptoms of dementia, BPSD it's commonly called. Patients might be prescribed medication to help manage those symptoms. Oftentimes those symptoms are going to be short-lived, and patients can sometimes be put on medication and left on it for a long period of time. And that's the kind of thing we'll be looking for specifically in those patients, whether the medication is still appropriate, whether it's actually fixing the problem it was prescribed to fix, and whether it's likely that the symptoms are no longer there and the patient can live without the medication. Some of the BPSD symptoms may not need medication at all, and especially in aged care, staff there are well trained at looking after patients, and hopefully they can use other strategies other than medication to help manage the symptoms. And that's the type of thing, again, we'll be recommending to doctors in dementia patients. There's two types of medicine reviews. There's a home medicine review, and that's where the consultant pharmacist will go to the patient's home, and if there's a carer as well, we'll have the carer there, and we'll go through all the medicine that the patient's taking, whether it's prescription medicine or things they might buy over the counter. We have a look at what the prescriber thinks the patient's taking compared to what the patient's actually taking. We check for drug interactions, we check to make sure the medication's actually in date. We check the dosing to make sure the dosing the patient's taking is what the doctor thinks. And then we write a report about that, and we deliver that report to the general practitioner. Then, of course, there's the residential medication management review, which is done for residents of aged care facilities. That's a process also generated by the doctor, where we do the same thing. We'll go through the medication chart, we have a look at what's been prescribed, we go through the doctor's notes, we talk to the patient and the carers about how the patient is, make sure medication's doing what it should be doing, and if there's any improvements or changes we can recommend, we do that. And again, we talk to the doctor about that. So the potential benefits for a patient, whether it's a home medicine review or a residential medication management review, is that we will be making sure that the medication regimen is optimal for the patient. So sometimes we'll find that patients have been prescribed one drug to stop a side effect from another drug. So sometimes we'll be asking doctors to modify therapy to alleviate the side effect so that the patient can cut down on the medicine they're taking. Sometimes we find patients aren't actually taking the medicine the doctor prescribed, so we'll be asking again to review the use of those drugs. So oftentimes we'll be asking doctors to cut medication down and cease medication altogether in some cases where it's either not effective or just not being taken. We can conduct a medication review for an aged care resident every 2 years. We can do it every year or sooner if there's a significant change in the patient. So if the prescriber thinks there's a good reason to ask for a review, they can ask for it earlier. The dementia patients will often have changes in their symptoms as time goes on, so it's not uncommon for patients to need reviews at least annually. Recently we've been doing deprescribing meetings at aged care facilities where we gather the team leaders, nurses and hopefully the doctors to talk about patients' progression and specifically looking at dementia-related medications and antipsychotics to work out a time frame for how well the patient's going, how long the patient's been on the medication, and when we should be talking to the doctor about considering decreasing the dose or stopping the drug altogether.
Internationally, there is a major move to reduce the use of antipsychotics. There have been black box warnings in countries USA, Canada, UK, France, and many countries are initiating strategies to reduce prescription of antipsychotics, particularly in nursing homes. There are many things that can be done in addition or instead of using antipsychotics, such as checking on the person's medical condition, seeing there's no medical indication for the behaviour, checking they're not in pain, looking at their daily routine. Do they have enough stimulation? Do they have enough activities? Do they have enough interaction with loved ones? So these are the things that the GP can institute, talking with the staff, talking with the diversional therapist, to try and minimise or avoid the use of antipsychotics. Person-centred care is understanding the person and meeting the needs of the person. So what are the person's preferences? We all have our own preferences, what the food we like, when we like to bathe, morning or evening, do we want to shower or do we like to bath, what we like to wear, what we like to eat. But often in institutions, people don't have a choice. Choice is missing. And person-centred care is trying to understand the person and their preferences. So it's important to understand what the person wants, what the person needs. And the behaviour is a form of communication. It's not a symptom always. It's a communication. And our skill as clinicians is trying to understand what the behaviour is trying to communicate to us. It might be communicating I'm in pain. It might be, as in one of my patients, I have a full bladder and I can't empty it because I have an obstruction. It might be that my neighbour, my other resident in the room, is driving me nuts because they're calling out all the time, so I'm getting aggressive. So the behaviour is a communication that we need to understand. And we need to direct management to understanding the person, understanding what the behaviour is telling us, and trying to meet the needs of that resident. There are supports available for people in nursing homes and in the community and in primary care, and that's the Dementia Behaviour Management Advisory Services, or DBMAS. These are freely available. There's a 1-800 number people can ring, and the nurses or the doctors or the families can ring up and get some advice about that.
There is growing concern that antipsychotic medications are being overprescribed to people with dementia. For patients with dementia, antipsychotic medication needs to be reviewed regularly. It's important to remember that antipsychotics may not treat all behavioural and psychological symptoms of dementia. Antipsychotics should be prescribed for no more than 12 weeks until either the behaviours resolve or a non-pharmacological solution is implemented. It's often the case that antipsychotics are no longer required when patient needs are identified and met. In most cases, it may be possible to reduce or deprescribe them. Managing antipsychotic medication in dementia patients is a collaborative effort. Successful deprescription requires close consultation between the patient's doctor, pharmacist, aged care staff, as well as the patient and their family, and can play a vital role in improving the lives of those living with dementia.